Excuse myself for talking English. Les autres colloids, other colloids. Just as an introduction, you've seen these data already many times, this meeting and other meetings, but we are all very well aware of the data that suggest that volume is bad for your patient. And as you can see here in the SOAP study, 1 liter extra of volume was associated with a 10% extra or higher risk for mortality, which is considerable. This is in AKI patients, and you see a lot of references underneath, but very nice from this Finnish study is that you can see that there's a dose-effect relationship. So the higher your volume balance is, the more positive your volume balance is, the worse your outcome is in your patients. So volume overload is bad, and therefore it kind of makes sense to use colloids to restrict your volume that is administered. Less is more. Okay, we discussed albumin, and the other colloids that can be discussed are gelatins and starches. I start with the gelatins. Surprisingly enough, there's not much prospective randomized data on gelatins in ICU patients. And I pulled out some data actually that are not prospective randomized trials, but are large observational trials, but with strong data. And this is data from Germany, and they observed three episodes of use of fluids. One episode they predominantly used crystalloids, the other episode they used predominantly starches, and the third episode was with gelatins. So, and 3 episodes in the same unit. And as you can see, hemodynamic optimization was not really different between the 3 periods. The lines are just on each other. And when you look at the volume balance, you see one line that's underneath the other. So 2 lines are associated with more positive volume balance and one with less positive volume balance. This is the starches, and these are the crystalloids and the gelatins. So gelatins do not really act as powerful in volume regarding to volume, less volume administration compared to starches, and they kind of act like crystalloids. Do they have less side effects? When I was young, I was taught that the gelatins are the safe colloids, and the starches are associated with acute kidney injury. Well, that's not really the case in this study. First of all, there's a dose effect considering mortality. So the higher dose you're given, the higher the mortality, and it's exactly the same in gelatins and in starches. And there's also a dose effect relationship considering occurrence of acute kidney injury. And you can see that the gelatins have the same amount of acute kidney injury as the starches. And of course, you should correct for other comorbidities, etc., etc. And when they corrected, the gelatins had the same signal as the starches. So the gelatins are not that safe, actually, and they are not so efficient because you use the same volume as the crystalloids. So this is a meta-analysis which illustrates my opening sentence that there's not much prospective randomized studies in ICU patients on gelatins. 3 studies, 700 patients, and therefore the conclusion here is very valid. The safety and efficacy of gelatin cannot be reliably assessed in ICU patients, and we need data. Starches. Well, this is data you're very well aware of. We discussed them in length in several meetings. Starches are bad, and maybe I can stop my talk here. We shouldn't administer starches. But I will go over the data and maybe discuss some challenging thoughts. The old starches, the second and first generation starches, were bad. They had a dose-effect relationship with mortality. The higher dose you gave, the more patients died. The higher dose you administered, the more patients needed renal replacement therapy. There's no discussion on these data. They were replaced by newer starches, and this is the recommendation that was put forward 2 years ago. The older starches should not be used anymore. But there was some questioning about the newer starches. We suggest not to use, but suggest is not as strong as recommend not to use. So there was some open space at that point in time. This was before the CHEST and the 6S trial and the CRYSTAL trial were published. Well, we know now about the 6S and the CHEST trial, and the starches story kind of has stopped because the European Medical Agency has put out this statement that they should not longer be used in patients with sepsis or burn injuries or in critically ill patients or in patients with hypovolemia due to blood loss. And if you use them, they ask us to follow up kidney function for that as long as 90 days. I'm not sure how we will be able to do that. So as of October 2013, the starches story kind of has ended. These are the data that supported this strong recommendation. The 6S study in severe sepsis patients showed higher mortality in patients randomized to starches. The CHEST study in general ICU patients could not demonstrate higher mortality. And we know about the CRYSTAL trial, published, I thought I had to sneeze, but it's not the case, published a few months ago. And as you can see, this is kind of challenging because there was no difference in mortality, but there was a trend for better outcome in the colloid-treated patients. So severe sepsis, patients die when they are administered colloids. General ICU patients do not die or maybe do better. I'm a bit hesitant to put that too strong, but okay, these are the data. When we compile all these data in a meta-analysis, mortality as endpoint, there's no signal. So mortality, there's a trend for increased mortality, but there's no increased mortality putting all these data together. The CRYSTAL trial is not included in these meta-analysis. Okay, acute kidney injury and modern HOSTE solutions. You've seen the slide already. Confusing data. So in severe sepsis, there's more acute kidney injury defined by rifle criteria. And in general ICU patients, there's less acute kidney injury. What do we make of that? How does it, where does this come from? Well, let's look at the general ICU patients, the CHEST trial. As you can see, creatinine increases in patients randomized to the HOSTE arm, and it's quite a lot. It's quite a large difference. But look at the axis. It's going from 100 to 110 micromoles per liters. That's not too much. So the real difference is 0.11. So there's an increase of serum creatinine, but only a slight increase. And it's because of this large number of patients that this number is statistically significant. And when we look at urine output, the other component of the definition for acute kidney injury, we see the opposite. So in the first 3 days, maybe it's difficult to see in the back, but the patients randomized to starches have a better urine output, have a higher urine output, which is kind of good. And this kind of, when you put these things together, kind of makes that patients, when defined according to the AKI rifle criteria in this CHEST trial, have a lower risk for development of acute kidney injury. Need for renal replacement therapy, kind of a more hard endpoint to define acute kidney injury in ICU patients. Virtually all studies showed a higher need for renal replacement therapy in patients randomized to starches. There's no real discussion on it. But let's have a closer look at the data. CHEST and 6S. These are the number of patients who developed need for renal replacement therapy in the HOSTE-treated arm, and these are the control-treated patients. And you can see it's significant, 0.04. But it's a simple chi-square. You can do the math yourself. If you change 2 patients, it's not significant anymore. So there's a signal, but it's not really very strong. Not as strong as it was in the older starches. Okay, what's this? This is in perioperative care. 2 meta-analyses, one from France, one from England, same data set, and they both showed that when starches were used in perioperative optimization, they were not associated with increased risk for acute kidney injury. So a limited amount of time of exposition to starches apparently is not that bad compared to longer exposure times. And the CRYSTAL trial, these are the outcomes. This is the outcomes table. And again, renal replacement therapy, 0.99, 0.90. There's no difference in need for renal replacement therapy in the CRYSTAL trial. 3,000 patients randomized to crystalloids or colloids. So that's quite a big signal. And 60% or 68%, I'm not sure, has patients. So makes you think. Other side effects. Patients will develop pruritus because of deposits of these starches in your skin and your endothelial system. Okay. That's correct. This is data from the 6S trial, severe sepsis patients, and they followed them up prospectively, and they asked for pruritus, and half of them had pruritus when they were randomized to the HOSTE-treated arm. So that's quite a lot. And this was long-term follow-up, so 1 year follow-up. Okay, but the control arm had exactly the same amount. And I forgot to put in the p-value, but it's not significant, of course. So pruritus is something that happens in survivors of severe sepsis, apparently. And the relationship of pruritus and starches is not so clear anymore in my eyes. Okay, let's step back. We are using, in our daily practice, lots of drugs with toxicity. ACE inhibitors, non-steroidals, aminoglycosides, heparin, calcium blockers, beta blockers. They all are associated with side effects. And we are very happy to use them. But we use them at the right dose, because it's probably for all drugs like that. When you don't give them, you don't have benefit. When you increase the dose, there's a beneficial effect. But when you increase the dose even more, well, you get harm, and that's probably also in starches. I'm challenging you a little bit. There's also an issue. I have a. My slide is visible on my laptop, but not on the screen.
Service technique, s'il vous plaît.
My time has finished. Yeah. I touched something. What's on the slide is that these 6S, CHEST, CRYSTAL studies are studies in ICU patients who are randomized to one treatment arm or another. Thank you very much. But they are when they are randomized into the colloid arm, they are administered these colloids for their whole ICU stay, which is strange, which is not something I do when I administer colloids to a patient with severe septic shock. First day, first 2 days, they are hypovolemic, they need fluids. Okay, I would have considered colloids. Not that, well, okay. But after that, when they have an episode of oliguria, the typical trigger for administering fluids, I won't give colloids anymore. But these patients were exposed to starches for the whole ICU stay. This is not really answering my question on colloids. And when you look at soft endpoints, but we should not forget to look at soft endpoints sometimes, we have some data that suggests that the more aggressive intravascular fluid resuscitation that can be obtained by administering colloids results in better surrogate endpoints such as capillary flow, which is probably good because it improves oxygen delivery to the tissues, or lactate clearance. So these are some slides in favor of colloids. There's this data from South Africa that suggests that patients that are randomized to starches have less acute kidney injury, probably because of better resuscitation. And there's data from several studies that suggest that indeed when you administer or you randomize your patients to colloids, you need less fluid. Although the difference is not as prominent or as good as we hoped for. Look at the Guidet trial, 1,400 mils versus 1,700 mils, a difference of 300. I would have hoped for more when and probably Dr. Guidet also, when he started the study, similar in chest. So the differences in volume are there, but are not as prominent as we thought they would be, probably because of the capillary leak. So this brings me to my kind of philosophical slide. We have studies with a heterogeneous patient population, and I think this provokes more questions than it gives answers. And we need more homogeneous studies in situations where colloids may make sense. Short-term administration in targeted populations. It's a provocative thought, but I would like to discuss this. Summary slides. Gelatins. They were kind of thought of as the safe colloids, the safe alternative for HES, although the data do not support this. And my take on this is that we should not administer gelatins. You don't administer less volume, and they have the same side effects. HES, well, there's no role for HES anymore in ICU patients. We are not allowed to administer them anymore. It's not because of mortality, maybe in severe sepsis, but there's some doubt in general ICU patients, so that's something we should think about. There's a higher need for renal replacement therapy, but the signal is not as strong as it was in the older starches. And it was not at all present in the Crystal trial, 3,000 patients. There's less volume, but less than hoped for. And so for the starches, I think we need good studies on short-term administration in specific cohorts. And that's my take on the future of alternatives. Thank you very much.